Hi, everyone. Thanks so much for joining us back after lunch. So hopefully this will be rousing and exciting so that you guys won't fall asleep after that wonderful meal that we just had. Part of it is my curse, so I need to apologize to my panelists because I am always either right before or right after lunch. So it's just, I don't know, it's just every conference I've been to. But hello, everyone. For those of you that don't know me, my name is Jason Lee. I'm the director of the Social, Behavioral, and Economic Sciences program at the National Weather Service in the Office of Science and Technology Integration. So thank you so much for inviting me to your annual meeting. It's exciting to be a part of this conversation and to talk a little bit more about outcomes. Right? You guys talk a lot about outputs and the science behind the models. I want to show you a little bit about where the value chain goes and what it actually does to actually impact people and some of the outcomes that we have. We have 4 wonderful panelists here today to talk a little bit about their research, some in hurricanes, some not. But it all talks about sort of how it actually impacts people and some of the outcomes either in public health, in emergency management, and sorry, I heard myself in an echo. And also talking a little bit more about some of the economic consequences around some of these natural disasters that are happening way too frequently, unfortunately. So without further ado, I want to introduce my panelists. They'll each have a 20-minute presentation, and then we'll have about 20 minutes to have a conversation. So please feel free to hold back some questions that you may have, but keep them ready. So our first panelist is Dr. Elizabeth Gregg. And she is currently an assistant professor of medicine at the University of Miami and is the co-director of the University of Miami Global Institute for Community Health and Development. She holds a bachelor's degree from the University of Pennsylvania and is a graduate of the University of Miami Miller School of Medicine. And she completed her internal medicine residency at New York Presbyterian Cornell and holds a certificate in community preparedness and disaster management from the University of North Carolina at Chapel Hill, where she was also previously a faculty. So thank you so much. Welcome, Dr. Gregg.
Thanks. This is a very cool opportunity for me to be here. So I'm really, you know, I rely so much on the people in this room to do what I do. So to be hanging out with you guys, I think is quite a neat thing for me. But I'll tell you a little bit about what we do. And I work primarily here in Florida. Used to work in North Carolina, so very hurricane-prone places. The Global Institute, just generally speaking, is the arm of the medical school at the University of Miami that does disaster response, primarily in our experience in, come on, in Latin America and the Caribbean. So most of my work has been in the Caribbean islands in the past like 10 years or so, and worked and lived in Haiti for a long time. Little bit of a tongue-in-cheek slide here, and I think what the take home from this panel is that you guys are, whether you appreciate it or not, are also public health practitioners, right? So you don't have to be a physician to have a public health impact, and what you do has a humongous downstream consequences and informs everything that we do in terms of hurricane response, to be sure. And, you know, I think the point of this slide here is that this is my day-to-day job, but, you know, that guy can't be killed by conventional means. So you don't really have to worry about this guy. And kudos to Florida Power and Light for keeping the power and internet on in this guy's house while it's half full of water. So, right. From a doctor perspective, we worry significantly about that particular scenario. I work also for Jaguar Land Rover, but I won't sell you a car in case, unless anyone's interested. And this is, I wouldn't say this is what we typically do, but this is what we do. So I think when people think of physicians in the field after a disaster, we think of sort of this kind of operation. This was our Haiti field hospital in 2010. And I'm actually a primary care physician, and you're going to hear from a bunch of people that do along the same pipeline as what I do. But we just had a discussion about really the very long-term consequences, health consequences, economic consequences of disaster that go way beyond what we intervene in a field hospital, right? So the emergency management, the immediate aftermath, that kind of stuff is one major component of it. But what I look at in terms of my research and my practice is really these like 5, 10, 20-year consequences of disasters. So these the impacts from a health perspective and many other social perspectives are very long-running downstream, and preventing all of this from happening with resilient infrastructure and accurate modeling and prevention of any kind is so important and has such long-term impact. So, you know, if you really don't think of yourself as a sort of public health interventionist on a day-to-day basis, you truly are. No pressure. And I think the one thing that we really like to emphasize from our perspective is that there's really there are no natural disasters, right? Disasters, you know, a hurricane that swirls around in the ocean doesn't cause me any trouble. It's the disaster impact is about the hazard itself, the exposure to people, and those people's particular vulnerability. And so when we're thinking about vulnerability, we're thinking about the physical infrastructure where the disaster occurs, the socioeconomic area in which people are affected, how many people are there, and what that infrastructure really looks like, and overall resilience. So keeping that in mind, you know, this is how we think about it, and then this is how we use the information that we're given. So I normally give this presentation and have not changed my slides in over a decade, I don't think, because medical students don't really know the difference. And then I realized that I was in front of you guys, and now I'm mortified to have this picture up there, but just pretend this is a more modern picture, and all familiar to you. But this is, and obviously from when I used to work in North Carolina, but this is what we call our decision arc, right? And Dulce can get into how we use these things and how she uses these things to make public health decisions about what to do with people when a hurricane is coming. You can see, you know, essentially what an emergency manager would look at here is, you know, if you're 48 hours or however many hours away from impact, then you have that piece of information. Obviously, the accuracy of that piece of information is essential to making informed decisions about what to do with people, instructions for emergency managers. And then the other things that go into your decision tree here are how many people live in what's going to get affected here, right? What do the roads look like leaving this particular area? How many people can you fit on a highway at one time? How long does it take that many people to make an exit out of a coastline that's about to be impacted by a hurricane? How fast moving is the hurricane? How big is the hurricane? What's on the land where the hurricane is about to hit? And then you can make decisions about how to move people. And just that decision alone is a public health decision that will cost lives, right? So there is a guaranteed life lost cost of people who don't evacuate their homes and get killed directly by the hurricane. There is a guaranteed number of lives that are going to be lost evacuating from a hurricane. So just in the evacuation alone, traffic accidents, heat, you know, all that kind of stuff, you are making a decision where you have to make the best public health impact decision you can make. And that is based on this kind of information, both the forecasting and the infrastructure and populations that you're looking at on land here. You know, here's kind of like an even older piece of information, but you can see, you know, you're looking at this county, this time, you have this many hazards, you got that many miles to go, it's daylight for these hours if you want to make a decision. You can't evacuate in the dark. You know, all these kind of like data points that you have to put in and make an overall decision about what to tell people to do. Famously, you know, this was an evacuation around the Houston area in 2005, and the models, you know, were spot on for Hurricane Rita. There was no trouble at all with the projection of the storm, as far as I can remember. It came on the heels of Hurricane Katrina, and the counties that were ordered to evacuate did so pretty effectively, more because it was fresh in their minds of what happened at Katrina, but a lot of other people evacuated too that weren't under mandatory evacuation. Almost 100 people, more than 100 people died during this hurricane, but the vast majority of them died during the evacuation. So having all of that accurate information going into what you're telling people to do, even in advance of the storm, that's absolutely essential. How people behave and what they do to assess their own risk is highly variable, and then depends on who those people are, what their experience is. That's probably the biggest thing that goes into people's decision making. Have they evacuated from a hurricane before? Are they fresh off the heels of another hurricane? Do they have kids? Are they impoverished? Are they sick? Do they have special needs? Is there shelter available? People have to make a very complicated decision about risks and benefits, just like they have to make on almost every health decision that you make in your lives. Do you want to exercise more? Do you want to stop smoking? You know, people make those kind of calculated risk assessments. It's very complicated about how people make those decisions. There is a ton of social science about how people make decisions, and how people make decisions in disaster. That's like the holy grail of trying to get someone to do what you want them to do, not do too much, not do too little. And this is kind of like one, you know, grouping of ways in which people make the wrong decisions in disasters. But I actually like this book. It's called The Ostrich Paradox. The ostrich paradox kind of refers to sticking your head in the sand, and then just ignoring all things coming at you, which is actually a pretty valid way to go about things, would you believe? But this kind of categorizes in a helpful way how people make decisions around risk. And, you know, and just to go through them quickly, the myopia sort of paradigm here. So this tendency to focus on very short future timelines. So you're not thinking about, you know, the long run. You're not thinking about protective investments. And I think when we are thinking about, you know, resilient capacity building in healthcare and other things, myopia tends to be one of the things that prevents us from making decisions that have to do with these real, like, long-term consequences. Amnesia, especially when it's a traumatic event, people really want to just forget that it ever happened. Forgetting the lessons of past disasters, not equating disasters to be like similar in nature to each other. So there's always this sort of, you know, sensation that that every disaster is unique, but really you can learn a lot from between disaster to disaster. There's so many commonalities in what we can take away as lessons from each of these things. The thing I like, optimism. So the tendency to underestimate the likelihood that'll occur from future hazards. Mainly when people think about bad things happening to people in hurricanes, that'll happen to someone else, but I'll be fine, right? And people do this all the time, that they're overly optimistic about their own odds of something bad happening to them. Inertia, obviously, I like that too, but, you know, maintaining the status quo and defaulting. And oftentimes when people have to make decisions in disasters, they're so complex that you actually sort of shut down and can't quite make a decision. And inertia is one of the biases that people lean towards. Simplification, and that's sort of a similar idea about considering all the facts, you know, a broad spectrum of facts that have to do about choices involving risk, and then doing what everybody else is doing. So in Hurricane Rita, if you thought, okay, they haven't told me to evacuate, but then you see your entire neighborhood clear out, you probably think like, well, maybe I'll do it too. So that's one way to think about how people behave. We just had a discussion that here in Florida, people are very attuned to hurricanes. This is our day-to-day, right? And so while there is a lot of sort of jest put towards hurricane evacuations, hurricane parties, and all that kind of stuff, and riding out hurricanes in clearly dangerous situations, people can absorb the messaging. They know what it means, I think, more so than other places. They heed warnings, and this is from our most recent hurricane here, obviously very rough data, and from dubious sources, although these guys are very reputable. This is data that actually came from watching people's metadata, and by meta, I mean Facebook and Instagram, like where they moved away from the coast on their cell phones. So like bigger population number, group numbers, not individual numbers, allegedly. And then you can see that people actually migrated away from those zone A areas and moved inland towards the coast, right? So I think this coastal impact, people understand, appreciate, they know what's happening there. And I think where the last couple of hurricanes have really highlighted some of the dangers and maybe the new dangers is that the impacts are obviously past the coast, right? So oftentimes, I think in probably, I don't know how it works in the modeling world, but, in the emergency management world, you do breathe a sigh of relief after it hits the coast and moves on and weakens a little bit. And then internally, you can, and then it goes off and does something else. Figuring out how to move people inland is very difficult because the egresses go in a million different directions. There are more people, there's more topography that the storm interacts with. And I think, looking at the new variables, inland hazards, the complexity of that topography, the complexity of the movement, unprepared populations. If you're living in a coast in Florida, you should know, what you're talking about. That's filtered into a lot of decisions you make about your insurance, about your housing, about all that kind of stuff. It's not so much in your decision, the front of your mind in Asheville, North Carolina. And obviously rapid intensification that relates to climate change changes the trajectory on which you have to make those decisions as an emergency manager. And I would just say, as a public health practitioner, me and you, I think, as a physician, having just gone through COVID, I feel this, right? If anybody's going home to their cousin for Thanksgiving in a week and is going to have a conversation about whether you control the weather or not, I just have a lot of sympathy for that. And at lunch, we were having this discussion about this one time I was going to quit, right? And I think as someone who has an impact on people's lives down the line, as you do, where there is uncertainty, where there is fear, where there is, just a scary impact, and you intersect with that in a way in your job function. These moments can be very disheartening. Physicians after COVID are sort of used to this, and it hurt badly. So I would say if you ended up, in having to think about this as part of your job, one, I have sympathy, and two, the end of that discussion that we just had about quitting is that you do have to be kind of relentless in this arena, and that's the bottom line. Like, none of us really quit, right? So I would just say, as everyone goes home and in uncertain times, dealing with uncertain stuff, from our perspective, we have sympathy for this issue. But that's it.
Thank you so much, Elizabeth. Now for our second panelist, Dr. Dulce Suarez is the Assistant Director for the Academy for International Disaster Preparedness, who actively teaches disaster management in a graduate program integrating practical experience with academic principles. Dr. Suarez holds a graduate degree in international relations from the University of Miami, the University of Florida, and the Florida International University. Welcome, Dr. Suarez.
Hello, everyone. It's a pleasure to be with you today. And the first kind of slide is just the title of my presentation, and I'm going to warm up. I knew I was behind Dr. Greg, so I was like, I need to bring it a little bit higher just because I knew Captain Marvel was going to take it there. But overall, I'm going to focus today on the role of the university, specifically FIU, and how we are invested in bringing a new workforce for what you're going to see now, which is not just disasters, but hurricanes in general. So there you go. All right. So let me tell you a little bit about myself. My parents and 100% guaranteed by Ancestry DNA. I'm from Nicaragua. I just got the results today. So for sure. But once I graduate from my bachelor's in my 20s, I really wanted to go into NGO, nonprofit world, but there wasn't a program what we have today. So I wish my program would have been existing when I graduated, but overall, I started working for the nonprofits. I got my master's degree and so forth, but I really focused on Latin America. And I did a lot of programs in management for USAID, and I have a lot of field work and so forth. But I wanted to prepare the next generation because I said, if this program didn't exist when I went, I wanted to expand on it. So basically after NGO, I joined Florida International University, and please raise your hand if you don't know about FIU. So I can go. No, everybody knows FIU? Oh, okay, great. All right, so I don't have to sell. But basically at FIU, I started and I joined the Metropolitan Research Center. Not a lot of people hear about it, but it's a research center and it focuses on various things. But one thing that we love to use is the census. So one of the questions that the American Survey asks, for example, is residents, it asks them, are you prepared for a hurricane? How many of you knew that that question is in there? One. Okay. Well, that question is asked to every single participant in the census. Most people answered yes, that they are prepared. When they were asked, okay, what do you have at home? Most of the response was the usual. I have water and so forth. But what we started to analyze in our research is that we're not asking the right questions in the American survey, and specifically when it comes to preparation. So those are researches that we did in Metropolitan Research Center, and you could see their publications and overall, and we focused on South Florida, but we also compared its preparedness when the rest of the United States. So that was very intriguing for me. We also have the hurricane, the wall of wind we were talking about during lunch. FIU is very invested in the wall of wind. We are actually building a new building called Hurricane Category 6. So expect that construction in 2025. So FIU is definitely driven to be the solution center when it comes to research and hurricanes specifically. But I work for the Academy for International Disaster Preparedness. And that is both, we wear the EM hat and we also are academics, and we try to mix them both. We want to make sure that everything that you see in a textbook, people are actually applying it. So that's really where the presentation is going to go to today. Overall, we started the Academy in 2015. And really why we started it is that we had a lot of first responders, a lot of firefighters, a lot of police officers who retired really young, and then they don't know what to do with all their experience. So we created a curriculum, both international and domestic. And why we say international is because we want to make sure that that person could respond to an international earthquake in Haiti, but could also go to Hurricane Katrina. And so what we did is we created a curriculum, and I'll share it with you today. And we want to make sure that it's not just the next generation, but anybody who is retiring or going to the public sector, private sector, is getting a curriculum that is really going to prepare them to what disasters look today, which is very different than 2015. So one of the first things we teach our students is the 4 cycles of emergency management or disaster management. Right. So raise your hand if you've seen the circle before. Yeah. Okay. So they call them the 4 phases. Now, this is my question. Where do you think all the money goes to? Which of the 4? Okay, so you see preparedness, recovery, response, and mitigation. Those are the 4 cycles. Most of the money goes to response and recovery. Why I say that is because most of the workforce, most of my graduates will go to response and recovery. The money is not going to mitigation and preparedness. And that's really where the research goes into mitigation preparedness. So we have a lot of, most of our billions of dollars, and we could see that in the next slide.
It's not going to work for a different computer.
Oh, okay.
So
Sorry.
you can just say next slide.
Oh, okay, next slide.
Sorry.
So no worries. But you can see here, for example, in 2024, all the billions of dollars are going to response and recovery. So it's very limited what we can do on the mitigation preparedness side. So one of the things that we focus on is education, is on preparing those people who are going to respond and be helping the victims and so forth. We need to prepare them to be able to tackle everything that they're going to see, right? Because all the money is going to response and recovery. One of the things I tell them is, now that you see Florida being hit so hard with billions of dollars that we lost, is that going to go to the public or the private sector? Response? Answer? Where do you think? Public or private? Private. So I tell my students, you got to go to the private sector. That's where the money is, right? Next slide. Now, overall, these are the things that at higher education we could focus on. First of all, academic programs like ourselves, training, making sure that they are understanding the skill sets. One of the classes we offered is called crisis communication. Most people think that they could talk to the public, but you could see that if the governor doesn't provide the right messaging, that will cost lives. So in our crisis communication class, which is taught by a communications professor, right? They're the experts in helping the students prepare and how you deliver that message. There needs to be training. It's not just natural to go on in front of the cameras and say, or for example, if you saw on Surfside, they had to do media reports every 3 hours and so forth. Those students that were in front of the cameras are our students. We prepare them. We also partner with first responders, but firefighters and everything. But we also have students of all backgrounds. Since COVID, we have nurses, doctors, public health, individuals that run the hospitals. We also have meteorologists. We have from all sides. That's who's taking our courses. So they need to prepare in the messaging. We need to be an interdisciplinary approach. We are not just one expert. We can't just say we're going to have professors who've written thousands of textbooks and research. No, we need guest speakers who are practical, people like yourself that are experts that come and teach the students what you know. So it needs to be an interdisciplinary approach. And the last one is we prepare them with practical experience and simulation. Simulation could be a tabletop, it could be a disaster drill, but they need to feel that they don't just know it in their minds, but that they could physically do it. And we'll go into that. Next slide. We try to educate the community and the students that if you have programs that are focused on disaster preparedness, on training, on being the next generation, you're going to have all these key takeaways. You're going to have resiliency. You're going to have faster recovery. You're going to have a culture that already knows each other. In emergency management, the question or the saying is, it's networking, knowing who you're going to see in the field. We try to have that culture in our classrooms. When a hurricane hits, my students already know each other. And also we try to have a diverse dialogue. We don't just want to have firefighters and police officers in the classes. We want to have a discussion with everybody. So it's all about culture. And we also want to create research that is relevant. If you have research that only policymakers are reading, then it's not doing anything. So you need to have infographics, things that really build that culture. Next slide. All right, so we think if there are economic and social advantages when a university has a program like myself, like the academy, or has conversations at the community level, or does dialogues, or does tabletops, you have all these positive impacts that you can see. You have stability, job creations. I tell students whenever they ask me, they're like, what kind of career can I have? I'm going to be a FEMA worker? No, you can be so many different things. The employment is there, and disaster management is growing. I think it's just learning the different levels that they could be involved in. I love it when the student is able to engage in their passion and together with new things or new skill sets that they have. Next slide. So how many of you heard about FEMA? Most of you, yeah. Yeah. So here in the United States, FEMA is who does everything from preparation, response, recovery, natural, disaster, terrorism, everything, especially now that it belongs to Homeland Security. So like I said, most students are like, I want a job in FEMA. It is so difficult for my student to get a job in FEMA. Not just because US Jobs is very hard or federal resume. It's mostly because FEMA actually hires all backgrounds and they think that it only focuses on one. So one of the things we do at the university is we partner with FEMA. We teach our students how to do a resume, how to build it, how to do everything. We want our students to be the workforce. However, natural disasters are occurring more and more and more. Hurricanes are multiplying. But we try to get them in the classroom and we have career work fairs and everything and so forth. And so there is the question of, why does a student get involved in natural disaster or in hurricanes or in disaster management in general? Next slide. And what I tell them is that they're moved, what they see on CNN, they are passionate about it. But I also tell them that they are going into a field that you're going to see multiple complex emergencies. Okay, so this is one example. In the FEMA's after action report in 2017, we saw that you have multiple hurricanes, kind of similar to what's happening in 2024. So in the classroom, we investigate what goes on, what was right, what was wrong. Most of the case studies are great for our students to evaluate on what they want for the next career. Next. But like I said, I asked them, why do you want to enter? So many students from South Florida told me Haiti earthquake, Surfside. They're very passionate about what they see, and that's why they come into the field. And then when we go over these case studies like Puerto Rico, that changes them completely. It changes them, and they want to be part of the solution. So a lot of our research is focusing on what went wrong. And we do tabletops and simulations, and we learn from it. Next slide. But for us, we work with FEMA because they need workforce. They need new career paths, right? So how do we educate our students on going this way? So that's something we do with them in general. But we know that FEMA has a really big problem. I mean, if you read their after action report, a lot of the blame of what happened in Puerto Rico is simply we didn't have enough workers. Same thing happening now. So there needs to be a collaboration between federal agencies and universities like ourselves in how do we get that next generation going. And again, there's a lot of partnerships. Partnerships is key for us here at the university, and partnerships is also key in research. Having them come into the simulations, and I'll go into the next slide. But one of the things we do is called the disaster field course, which Dr. Greg has helped me last year. We do it in July. It's very hot in June. We try to do as much realness as possible. And I always invite all agencies to come and see. It's also the best ground for research. You'll see that their mental health, so it's the most controlled setting we could do, but we simulate, and you can go to the next slide. We simulate everything from response to helicopters. We have agencies, we have US Southcom, we have everything. We want the student to take away that they are in a real disaster, and this is the elements you're going to see. We also have subject matter experts like Dr. Greg and so forth from South Florida and federal and all types of agencies that come and support us. And it's a great way to do research on what is the impact on the first responder or the person who is helping. How do you teach them to talk to tribal? How do you teach them to talk to a country or victims that don't know this or don't speak English, which could happen, especially now that Hispanics and Latino communities are so pronounced in some areas where these are affected. So that is taught at the university level. That is taught in a program like ours. That's not something that is one and odd. It is a trend that we're seeing. More programs are arriving with emergency management, homeland security as a central focus. I tell those programs try to focus on bringing practical and theory and research to the student that's going to be involved in the next response and recovery. This is just an example. FIU is huge. We have multiple campuses. We do our simulation at Key Biscayne. Actually, not Key Biscayne. At Key Biscayne. Virginia, no. Biscayne campus, yeah, but it's near Oleta State Park. It's beautiful. It is hot. It is unbearable. No CMs. Everything will tackle you. Okay, raccoons and cats will come about. But we submerge our students. I feed them MREs. And most of the time it's not just physical, it's mental. And so you don't get to see that exposure because usually in disasters, everything's going on. It's very chaotic. But here we focus on the response and recovery, but we focus on preparing and training the student. And we also get amazing data on the students afterwards through surveys and things that we collect. Most students will tell me that they're super prepared. Happens, they're crying like babies. That's the truth, okay? I could prepare them, tell them all that, we use GIS coordinations, we do everything we can, but the truth is that it reveals to us that they're not prepared. Next slide. So you're always looking for future research at FIU. For example, myself, now that I have a mom and, I have a child with some developmental delays and so forth, I focus now, for example, on how the university is involved in collecting data and how do we get assistance to individuals with disabilities and how do we prepare them when it comes to a hurricane? Is Florida prepared? So for us here at FIU, we're growing. The research is just amazing, but there's so much work to be done. So thank you so much.
Thank you so much, Dr. Suarez. So our next panelist is actually online. So Jacob, are you with us?
Yeah, I am. Can you hear me?
Yep, we can hear you. So quick introduction before Jacob goes into his presentation. Dr. Jacob Fuchs is a research associate with the Cooperative Institute for Research in the Atmosphere, supporting the National Weather Service's Social, Behavioral, and Economic Sciences program. His work focuses on the economic and social impacts of weather and climate and the behavioral response to weather information. So prior to joining CERA, Jacob also worked for the USDA's Economic Research Service and in the insurance industry. So welcome, Dr. Fuchs.
All right, thank you very much. So, we just had two kind of very engaging presentations that I found very interesting. And now I'm going to sit up here and talk about, from a screen, about, quasi-experimental statistical methodology. So, here we go. Let's, next slide, please.
Sorry, 1 second.
Okay.
There we go.
All right. So here's what I'm going to talk about. So I'm going to talk about heat today for the most part, right? Heat causes the most fatalities of any weather hazard in the U.S. And the primary product the Weather Service has in terms of reducing heat mortality is our watches, warnings, and advisories, right? In fact, this is our primary output when interacting with the public in general. So I'm an economist. I work with the Weather Service. I get, the usual question that I get is, how do we quantify, how do we justify the effect of our products to Congress, to the budget people and the executive branch, because we do all of this good work and it has all of these great outcomes, but they never give us enough money to do what we want to do. So how do we make this argument? And that's actually a really hard question for a number of reasons. I'm kind of talking about a methodology here to approach that in a particular circumstance here. I'm going to be using what's called a regression discontinuity approach, basically looking at mortality data and using this arbitrary threshold with watches, warnings, and advisories. I'll talk a little bit about that in a minute to kind of try to get a quasi-causal estimate of the effect of that. And the headline result here is that these products prevent on average of at least, and this is a very conservative number for a variety of reasons, 52 deaths per year. So that's kind of what I'm going to try to convince you of as we go through this. Next slide, please. All right. So first off, wait, right, this is a hurricane thing. Why am I talking about heat? So let's back up a moment. Next slide. Okay. So the National Weather Service mission includes protecting lives, right? Lives, property, support enhancing the economy. In terms of protecting lives, especially, the primary product we have is our watches, warnings, and advisories. So again, there's a simple question that I get all the time. How effective are watches, warnings, advisories in in creating outputs here? The output that I'm looking at in this case being mortality. And there's sort of an obvious corollary to that, which is often not what people are thinking of, but what I'm, the way that I think about it is, while I do benefit cost analysis guy, I'm not a benefit cost analysis guy, right? I like to think of trying to quantify the outputs of our different products and our different policies in order that we can study the effectiveness of them, and how does the effectiveness change as we change things, or over areas or over populations, that sort of thing. But in order to really get at that, we need to somehow quantify the effect of these things on the population or on whatever outcome that we're interested in. So in order to measure that, we need to be able to, or in order to measure the effectiveness of changes, we need to measure the effectiveness of the policy on some sort of outcome that we're interested in. And I'm trying to hit next slide, please. All right. So again, this is a simple question, but assigning causality in social science is really hard, right? Like, everything is correlated. There are all these feedbacks. Often the data isn't nearly as good as you'd want it to be for a whole variety of reasons. But there are a number of approaches we can consider, right? And it's, as an econometrician, sort of doing applied econometric statistical stuff, the jargon that we often use is, what is your identification strategy? Which is basically, what is the sort of minimum number of assumptions that you need about your model, about your statistical approach, in order to say that, yeah, we're pretty confident this is a pretty robust estimate of the effect of this program, right? I mean, of course, talking about causality whenever you're talking about statistics is touchy, but we want to be able to hang our hat on as strong of a thing as we can. And whenever you have this sort of natural discontinuity in a program, so looking at watches, warnings, advisories, there are discontinuities over both time and space, where there's thresholds, both in terms of county warning areas or polygons, however the product is issued, and this, looking at communities on either side of some sort of jurisdictional boundary is a way that this methodology has been used a lot. And also, you have these thresholds in terms of when we issue the warning, right? So in this case, there's a threshold that says if the heat index exceeds this, then we're going to issue a warning. Now I say that and I throw around this number, 105 degree or heat index of 105 here, which is actually totally false. It's kind of a rule of thumb, but there's a lot of variation around this, even like within a WFO. Different counties may have different thresholds, and different types of years will have different thresholds. So, it's not quite as clean as I'm sort of making it out to be, and I'll discuss that a little bit, depending on how far I manage to get into the weeds of the methodology on this. But I'm focusing on heat specifically, sort of a first pass with this methodology, because first off, heat has high mortality rates. So there's a lot of data on heat mortality, depending on who you ask and how you cut the numbers and how you define things. Some people say it is the highest natural hazard related cause of mortality out there, although I've heard that about like 4 different hazards. So that's going to be a paper someday. But also, there's relatively simple thresholds, right? We're just looking at a heat index, whereas for some other hazards, it can get a little bit more complicated than that, right? So go ahead, next slide, please. So again, going back to this question about how do we sort of assign some sort of causality or get close to causality, looking at the effectiveness of these things. So, right, our gold standard is we do an experiment, right? So how would we do an experiment here? Well, maybe we withhold our watches, warnings, from a random sample of the population and see how many more people die when we do that, right? This is I like to, the mad social scientist approach. Of course, this is extremely ethically dubious, right? We wouldn't do this. And even if we did that, I couldn't get that paper published because, of course, you have information information effects, and you can't control information flow within the community. You have to figure some way to deal with that. But anyway, there's actually better ways to do this, right? We can do randomized controlled trials if you have like a phased rollout of a product or something like that, but that's well beyond the scope of what we're talking about here. Next slide. So option 2, right, and this is going back to my undergraduate econometrics class. You have some data, you have some other data, you want to figure out the cause of the effect of one on the other, so you run some linear regressions, right? So maybe we can look at mortality as a function of whether a warning has been issued. But if you do that, and I actually did this just to, like, if I was going to be talking about this, I wanted to be able to speak authoritatively. If you run this regression, you see that warnings increase mortalities, right? Which is not what we're expecting. That's not what we want to see. But of course, there's like confounding things here, right? The warnings are correlated with higher temperatures, of course. So really, they're sort of representing a proxy for temperature. So, well, maybe we can include temperature variable in there. It's still positive. There's a variety of reasons why. But then you need to mess around with specifications and all of this stuff. And you get into very quickly into sort of scientifically dubious practice here by trying to kind of hack your model in order to get a result that makes sense. And there's always all of this unaccountable, uncontrolled for variation that you see in this kind of thing that really prevents you from running a simple linear regression and saying, even if it like includes all the data you can possibly get, it doesn't work out for you very well. Or at least you wouldn't be able to get it published because anyone will look at it and start arguing with you about something. Anyway, next slide, please. All right. So this is the approach that I'm looking at here, regression discontinuity design. I'll talk about it a little bit more. This falls into a general basket of what we call quasi-experimental methodologies, which have been sort of a hip thing over the last couple decades, where we're taking advantage of some quirks in the data or some natural experiments or circumstances, which we're able to really make a much stronger causal argument based on statistical theory about the model and probabilities and all that sort of stuff, which I'm not going to dive into. But the regression discontinuity design in particular applies well to any sort of circumstance where you have some sort of treatment assigned based on an arbitrary cutoff of some continuous measure that's correlated with the outcome of interest, right? So, and when we have this and you have a set of assumptions that are satisfied, then we can consider this to be as good as randomly assigned, right? It is basically as good as a well-designed experiment. This was a lot of the early use of this was for like education programs where there's some test score threshold where you have this notion that you have like natural ability and then people around that threshold, right? Whether you got a 800 or 799 versus 801 on your GRE or whatever. Well, GRE doesn't go to 801, but whatever, right? Like whether you're within a couple points of this threshold, all of the kind of underlying confounding stuff is basically the same, right? Your difference between around this threshold is basically random. So if you look at assignment based on this threshold, it's as good as random assignment. In this case, our outcome variable is our data mortality count in a county, daily mortality count due to heat. I'll talk about that in a minute. Our running variable, which would be the kind of continuous variable that is correlated with this outcome, is our heat index, and then our treatment variable is whether a heat index or whether the heat index was passed so that the warning was issued. And I put 105 there again. It's not 105. There's a lot of variation in this, and that actually has to be modeled in sort of a two-step model. I'll talk about that in a moment. But basically, the sort of gist of this here is that the effective heat at 104 is essentially the same as the effective heat at 105. Or there's a linear relationship here, or an exponential relationship. In this case, it happens to be that you can model, and you see a jump at that threshold, and that jump you can attribute to exposure to the watch warning, the Weather Service product, right? So next slide, please. All right, so next slide. First, we'll look at the data a little bit. I think the interesting thing here is the mortality data from a data perspective. We used CDC multiple cause of death microdata from 2005 to 2021. So the data that we have here is individual level data, where each record is a single person. It includes date, county, diagnosis code, all this stuff. And then we aggregated this to a county by day basis. So we say for each county, for each day during this time span, how many people died of heat in one way or another. One limitation of this, of course, is that the coding is conditional on how the coroner or medical examiner, however, whatever official coded the death certificate, codes it, right? And we know that frequently heat may show up on there, but the primary cause of death may be cardiac, may be substance related, may be respiratory. So there's all of these things that you have increased risk of mortality, which is associated with increased heat, and whether heat ends up on the death certificate or not is questionable. I looked only at cases where heat was identified as either the primary or secondary contributing factor in terms of the mortality. But we do know that there's excess mortality during high heat events that are 20 to 30% higher than what we see coded. So, right, how much do I care about this? Does it introduce bias from my perspective? I would argue that, right, this is sort of noise. I'm not sure that the cases coded that way would necessarily be systematically biased one way or the other in terms of the treatment effect that we're interested in. But next slide, please. All right. And I'll run through these next pretty quickly. A lot of them are really focused on some of the details of the methodology. I'm not sure if these are going to be made available or not, but of course you can get in touch with me. I'd be glad to share this or discuss this with anyone who's interested. But the primary diagnosis code that I was looking at is X80, which is exposure to excessive natural heat. Across the entire period that I was looking at, we had almost 10,000 records where that was the primary cause of death, another 6,000 records where it was a secondary contributing cause of death. One thing that I thought was very interesting as I was digging into this was the primary codes where it was a secondary case, and cardio and respiratory are the primary one, but sort of a major second runner-up is substance related, either prescription drugs, alcohol, various things ended up being another major sort of primary cause where heat was a contributing factor. So not terribly relevant to this analysis, but an interesting thing that I wasn't necessarily expecting. Next slide, please. All right, so I'll just give you this, again, brief overview of the data. I told you about the date range. The total sample, we ended up with about 4.5 million county days. Again, it's each county by each day over this period. I ended up trimming down the sample a little bit, so I wasn't looking at September, months where there wasn't any mortality, that sort of thing. There were total mortality days of about 12,000, total mortality over this of about 14,000, and I sort of had a summary there. The number one, there was, let's see. So we had one day there where there were 27 mortality cases within one county. That was somewhere in the Pacific Northwest, oddly enough. So that's just sort of a numerical distribution of what we saw. Next slide, please. So the heat and humidity and heat index data, I all ended up getting from OSU PRISM climate data, watch warning advisory data got from ISU's environmental mesonet, which has all of the historical weather service watch warnings advisories issued as part of the VTech archive. Those are sort of the two other main things, or perhaps not that interesting. Anyway, next slide, please. These are a bunch of modeling decisions. I'm not going to dig too far into most of these, right? There's sort of your specification. You want to, when you have count data, often you're thinking of this as a Poisson, negative binomial, whatever. A lot in terms of specification of the heat variables. One thing that's notable with heat is often you have this lagged effect, so that it's not necessarily just what's the heat today, but what's the heat over the last several days. I ended up including 2 days of lag max temperature. And then there's this threshold question, which again I was throwing around the 105 degree number earlier, but that there ends up being a lot of variation in that, which I explicitly had to model here. So next slide. Yeah. So let's talk about this threshold, right? So there's you see the number 105 heat index over 2 days floated around as sort of a rule of thumb. It varies over geography, varies over season. It's not a strict cutoff. There's other things that goes into this, including forecaster decision making. So this becomes what we call a fuzzy instead of a sharp regressing discontinuity. Basically, and go next slide. The way that I ended up modeling this is sort of having the probability of a warning being issued as a logistic regression that was a function of the heat index in that county at that time, and then a bunch of other variables that are controlled for county and seasonal effects, because they definitely vary with season. And then I fitted a predicted likelihood of a heat warning being issued on a particular day, and use that as the independent variable in the second stage regression, which we're actually interested in looking at here. Which, yeah, this basically, you know, it's sort of, it adds a little bit of noise to the estimates, but it won't introduce any bias. It'll still give you an unbiased, good estimate of the effect. So, next slide, please. All right. And I'll just have a minute or two left, so I'll go through this pretty quick. But key result here is that when a warning is in effect, it reduces mortality by about 0.07 lives per county day, which is not a lot. But given that we had almost 12,000 county days over the period we're looking at, that adds up to about 831 lives saved over the study period, about 52 lives per year. So if we want to use the value of statistical life, which, you know, if you're not familiar with that, it's basically trying to, you know, an estimate for how much people are willing to pay for small changes in the likelihood of death, and then you can aggregate that up to a larger number, which, you know, the Department of Transportation uses $13.2 million per life. So yeah, we can put a number of $676 million per year on this, which then is something that, you know, we can give to Ken, or, you know, whoever is doing the budgeting stuff, and they can use that to argue that, you know, we need more support because this is a very valuable thing to society. All right, next slide. I'm going to skip over this next slide. This was interesting data. There's a lot of interesting things in here. But the last thing that I wanted to talk about, since I'm pretty much out of time, is all right. So this is a hurricane thing. I've been talking about heat. But the point that I wanted to make here is that this is something that can be fairly easily transferred to other hazards, right? As long as we can think carefully and identify some thresholds of who is exposed to the warning and who is not. So in a hurricane context, timing is perhaps an issue here. Space is an issue here, right? You can look at who is within versus without a warning area and see how that changes behavior, not necessarily in terms of mortality, but in terms of who is choosing to evacuate and who is not choosing to evacuate, who is making preparations, who is not. So that's, I think that's the food for thought that I wanted to leave you with here. Again, I think this is a very strong, robust methodology. I think this is a very important question of how do we measure, define, and then attribute the outcomes we have to weather service products. So that said, next slide. Thank you. You know, my email address is there. Please do feel free to reach out. And I think I am out of time now. So thank you.
Thanks so much, Jacob. If you could stay on the line, we'll have about 20 minutes of questions after our last, but our final presenter today. He's our ringer. Dr. Laramie Kolff is an associate professor at the University of Oklahoma Health Sciences Center and holds the Donna L. Wong Professorship in Pediatric Medicine at the Fran and Earl Ziegler College of Nursing. He's also a senior advisor and research liaison, health informatics with the OU Health Hospital and Healthcare System. He focuses on health policy, data analytics, the health consequences of disasters, and teaching in the PhD program. He's also a senior fellow with the University of Oklahoma Center for Intelligence and National Security. Welcome, Dr. Kolff.
Nope. So like most of the other speakers in this group, I am not a weather forecaster, but I absolutely love what all of you do and have been using it for a very long time. I'm a faculty member, a researcher now, but until a couple of years ago, I worked for Homeland Security and Health and Human Services doing medical response to disasters. So I was in the NRCC when you all were giving your briefings every morning. I was the director of planning that I would look every day, multiple times a day at what your predictions and forecasts were, and then have my team of 40 planners developing response and contingency scenarios based on what you were doing, deployed down in the field multiple times, especially for Harvey, Irma, and Maria. And I can tell you, as you all talked yesterday about who are the users, who are the customers, and what impact do your forecasts have, they're amazing. They do so much, but there's so much more that they should be doing. This picture here on the left is actually from the only health clinic on Vieques, one of the outlying Puerto Rican islands. This was their emergency preparedness plan. Back behind the clinic, they had a generator, but no fuel, and a whole bunch of beer. As you can imagine, their clinic closed and stayed closed for a very long time. And so how do we take what you do and have it be more impactful? As Ji-Soon said, what is the difference between the outputs and the outcomes, and how can we combine the two of those together? Now, if I was actually a really good social scientist, I would have anticipated that this was what the conversation was going to be about, and all of the talk yesterday about end users. In reality, this is more of an even a blind squirrel finds a nut, because it's kind of what I talked about, but it's more just sheer dumb luck. Next slide, please. So I wanted to talk to you a little bit about the differences between forecasts and health consequences in particular. We can talk about economic, but they're kind of the same. Exact same thing that you all talked about with the Carolinas yesterday, that almost all of the deaths were inland flooding far, far from where the storm was hitting intensity. Here's a couple of other examples. Hurricane Michael, 2018, Category 5, big, bad, scary. Everybody was really worried about it. There were 16 deaths attributed by NOAA to Michael. 8 of those were in Virginia and North Carolina. So half of them were far away where this was a tropical storm, or not even a post-tropical depression. If you compare that to Tropical Storm Allison in 2001, which barely was a tropical storm at landfall, there were 22 deaths in Houston alone in a single city, and 19 of those were from people entering floodwaters. So when you talk about the outcomes versus what the forecast is, they're very different. But that doesn't mean that we can't figure out what characteristics of the storm are leading to these bad outcomes. What if in the forecasts we could include what those impacts are on health, so that we could better inform the messaging, so that as Jacob was talking about, we can have more of an impact with our watches and warnings, because we know the difference between, well, bad example, know the difference between 104.5 and 105.5, but more know the difference of when a tropical storm is going to be highly impactful on health and when it's not. Next slide, please. So there's a lot of different ways at looking at health consequences. One that I've been working with one of my graduate students on is, when should hospitals activate their emergency operations plans? So the best advice that we could find is that some best practices from ASPR said that you should do alert notification. You should start activating your emergency operations plan whenever there is a watch or warning issued from the National Weather Service. Might sound good, but the number of times in Oklahoma that we get watches and warnings means that we should be activated 182 days a year on average. It was one of the reasons that I moved to Oklahoma, was for this. In retrospect, we all make poor life choices. If you look, so I went into health IT in my hospital and healthcare system. So I went in and looked at the ED census, the number of people going into the emergency department every day, and then mapped on top of that the days that were recorded as storm events in the National Weather Service storm events database. And then I looked at those differences. Were the days with weather events, not just watches and warnings, but events, did they result in us having more people in the emergency department? Should we have been activated for them? On non-storm days, our average census was 124. On storm days, it was 120. It decreased in a statistically significant manner. Now this is just very preliminary, 2 years worth of pilot data. We had 2 Stafford Act declarations during that. They were both for fires, so they weren't even real weather events, but it was hot and there were some other issues. A 30% decrease in the number of people coming into emergency departments for the entire declaration period. Now, it maybe went up a little bit after that, but I don't have enough to really look at it. What we're doing with the messaging, with the operational impacts from your weather forecasts is wrong. You all get it right, we're getting it wrong. So how do we take your information and the other factors around it? We talked about storm surge predictions. We talked about so many other amazing things that you all are doing. How do we, as social, behavioral, economic scientists, better use your information for the messaging and the outcomes? Next slide, please. So I've been working at this for a long time, kind of bouncing between jobs until I can finally get all of the right data pulled together to do this properly. Something that I did with the Healthcare Cost and Utilization Project data from the Agency for Healthcare Research and Quality, another part of HHS, was to look at in hurricane impacted zones, how many people went into emergency departments or were admitted as inpatients into the hospital with a baseline of 2 months before the hurricane hit, day of landfall, and then following it for a few weeks afterwards. In almost every case, from landfall through a week, we see dramatic decreases in emergency department visits and hospitalizations. Now, usually after a while, that trends back up, and up until about 8 weeks out, you're seeing those increased numbers come afterwards. But when we're talking about sending out NDMS teams, setting up field hospitals, bringing in extra staff, we're doing it at the wrong time. NDMS teams come in to do surge for 2-week periods. They're coming 3 days before landfall so they can be there and prepared. By the time their 2 weeks are up and we send them back home, that's just when patients are starting to come in. We are doing the wrong things with your forecasts. Next slide, please. So when we look at economic consequences, this is kind of the same things. These are not my numbers. I have ways of measuring them and looking at different aspects of them, but I'm not there yet. So you get somebody else's numbers and you're welcome. They're prettier than mine. If we look at the most expensive hurricanes and disasters, they don't match the scale of the storm as we put in our forecasts. Tropical storm, category 1 and 2 and 3 are a lot of them here. That doesn't mean that the forecasts are wrong. It means that we're using them wrong. Next. So what does that mean for operations? This is one group of the end users. One is the watches and warnings, the evacuation messaging. How do people know when they should leave? But a big part of it is the hospital and the operational response community, the different emergency support functions under FEMA. I mostly worked in ESF 6 and ESF 8, so mass care, emergency assistance, sheltering, and then public health and medical. There are a lot of disasters. Hurricanes are a lot of the big ones, the major disaster declarations. But one of the reasons that I went to Oklahoma is there are more, since 2000, there are more emergency and major disaster declarations in Oklahoma than any other state. When you look at the deaths, the different consequences, they're different there. But how can we use your forecasts for hurricanes, but also for other weather events to better pre-position, prepare for, and respond to these disasters and help accomplish your all y'all's goal of saving lives, property, and saving money in these disasters? Next slide, please. Some of it is in the directly impacted area, but some of it is understanding people's behaviors and what do they do. This is something that You talked about direct relief and crisis ready and their evacuation messaging. This was in their beta period stage when they were using cell phone location data because it was enabled during COVID, as well as the Facebook for Good check-in information to look at when people deviated from their normal routine. So if they on a regular basis were at home and work during the weekdays, then it would show up as these are their normal locations. So this is deviation in advance of the hurricane when evacuation messaging was given for Lake Charles. Where did they go? When did they go? And how long did they stay gone before they came back to their regular routines? So this map shows where they went to, what sort of the major distribution areas were, and then it also overlays the hospital data, the emergency department visits on top of that. What is absolutely astounding to me is that about 50% of the population left Lake Charles. 2 of the hospitals there closed because of the hurricane. The ones that were remaining still had 50% fewer patients during that time coming in, even though it was really bad hurricane. That population started to come back up when people were going back to their home city. But even though Lake Charles is not a small place, when you look at where they went to Houston. And emergency department utilization in Houston increased by 3 to 5% during that period. For that small of a group to go to Houston, which is massive, and have that measurable of an effect means that the people that are evacuating, as we heard earlier, are highly vulnerable. Not only are there deaths due to the disasters, but people forget to take their prescription medications. They don't have their script with them. They don't have doctors there. So they end up in the emergency room taking up the limited health resources in that area, which is great. They need it. But if we can come up with better ways of including consequence measures in these forecasts, we can help decrease this surge on the healthcare system. We can help people be better prepared. We can send our teams to Houston and New Orleans instead of Lake Charles so that we're putting the resources where they're going to be needed. You all are so amazing at what you do. I really want the rest of us to catch up to it, to be able to use it for these impactful measures. Where should they be going? How do we distribute people? How do we set up the supply chain to get them there? Right now, they're getting supplies into the Carolinas on pack mules. If we would have thought about this beforehand, we could have pre-staged a lot of things that might be needed. So we really need to come up with algorithms with forecasts for consequences that take the information that you all have and do something more with it. Next slide, please. So what can we use this for? Who are the end users and what are the impacts that we can have with your forecasts and the general information? Evacuation messaging is a really big one. As Jacob told us, it saves lives. Now I tend to shy away from mortality as a measure because those aren't people that I can help anymore. As the healthcare system, if they're already dead, we're too late to do anything. But the people who are going into hospitals or have other needs, that's why I'm looking at the number of people going into emergency departments and being admitted to the hospital. We can do things with pre-deployment of response resources. Those are things from ASPR, which does the medical components of a FEMA response, but FEMA as well. Water, generators, fuel. But also these medical response teams. How can we set up tents in the right places where people are going to be going and where they're going to be needing the resources while ensuring that those responders, those docs and nurses are safe, that we aren't sending them to the worst place. Hey, everybody, evacuate. This is going to be awful, but let's send all of our doctors and nurses there in advance. If we can wait until a week later and send them in afterwards, that's great. So it's not only pre-deployment, but it's later deployment so that they're matching the need while avoiding the risk. Hospitals being on divert are a huge deal right now. After COVID, this means that they usually for emergency departments, they don't have the capacity, they don't have enough medical providers, and they don't have enough beds to accommodate more incoming patients. And so they have to say, hey, don't send us any more ambulances, nobody come here, go to other hospitals, we need to transfer people. And I apologize, that's a terrible description of it, but please forgive me. How do we have hospitals be our end users of these forecasts? How can they know when they need to go on divert so that they can take care of the patients that they already have? When should they be evacuating out of their hospital to send them to other places? How can the system accommodate more of what's going on in surrounding areas? Supply chain is incredibly responsive. My computer died yesterday. As soon as we started the meeting, I didn't know if I had slides. I didn't know what was going on. My grad students, my postdocs, everything that we pretend is a disaster and important in life. I freaked out when my computer died. So I called my friend in our IT department and I said, did you do something remotely to push to my computer that made it die? And he said, no, you just have terrible luck. He figured out what I needed. He took my credit card, he called the Apple store, he ordered it, and he had Uber deliver it to my hotel that it was waiting for me when I got back from the conference last night with everything loaded on it and ready to go. If we can do that for new computers and iPads and technologies, we can do a whole lot better than we're doing with the supply chain, just both the general supply chain and the medical supply chain. If we can use your forecast to know where we need to get things, Amazon, Waffle House, Walmart, the Apple store, you need to keep the kids entertained. There are so many things that we can do better. Opening shelters, there are so many people going into shelters, and they're often the most vulnerable. If you have money, if you have resources, if you have capabilities, you're going to stay with family and friends, you're going to call it a spa weekend, you're going to go to a nice hotel somewhere. When you need to go to a shelter, these are the people that we most want to help. When and where should we open these shelters? What should we do with them? What do they need to have at them for the resources? And then staffing, who needs to come into the hospitals? It's pretty hard when people are both the victims of the disasters and they are the responders and providers who are helping. If we can have them home with their families, making sure their house is okay, taking care of their kids, instead of coming into the hospital, but coming into the hospital when they're needed, that's better on everyone and everything. So these are just a couple of the things that I thought. I'd love to hear what you all think of who else are the users and what are the impacts of what you're doing so that we can use your information. We can do more modeling and forecasting around it on consequences and together make more impacts with what's happening downstream. So thank you all for your time. And then I'll turn it back to you.
Thank you, everyone, and thanks so much for all of our panels of speakers. So now I'd like to open it up for some questions, and I will warn you all, like, you better have questions for us, otherwise we're going to have questions for you. So
There are some in the chat that came in as well. Should be able to see it on the TV screen there in front of you. Let's see.
oh, okay, so kind of read to see which is the question.
It's the right above Mike Brand, so the longer one from Dave Jones was his questions.
Dave, do you want to tell us your question?
Hi, sure. Can you hear me?
Yes, we can.
Yeah, I was just wondering that, we work with emergency managers throughout the private sector and the value and supply chains. And one of the biggest questions that they ask us is, where are the evacuees going? When they get an evacuation order and they leave town, where are they going? Because the groups that we work with in the private sector, and it could be anywhere from Walmart to utility crews to things like that, they want to know where they need to build up their products and services to serve a higher population of people. Is there a way that we can find that out, because that's really not NOAA's job. NOAA's job is to give the forecast and try to provide impact-based decision support services, but they don't tell people where to go. Thank you.
So the easy answer on that one is, since we're in Miami, north, that's where they go. In reality, it varies dramatically. And this is where a lot of social science and studying human behavior comes in. They go where they're from. They go where there is easy transportation, where the roads are directing them, and they go where they have family ties. That isn't necessarily helpful for what you're talking about in messaging, but that's where some of these new, I was going to say tracking, but that's the wrong word, population-based movement studies and simulations, that should be politically correct enough, can help us figure out where the populations have gone historically and lead to modeling of how does this group respond. Is it a general movement plan, or is it based on the predicted storm path of the hurricane? But looking at other disasters can help us understand what's the general behavior. And if we can build up enough of this, then we can know where people are going to go in measurable ways and know before the storm comes. We're not quite there yet, but we're getting a lot closer than we used to be.
And I would say that thank you, that one thing to think about is that, and my gestalt, I don't know, this might not be evidence-based. It's not evidence-based, but is that vulnerable populations might not be going very far. So if you have, and they're really the highest risk, they're just the highest risk. If they have to go to special needs shelters, that's going to be relatively local. If they can't afford to get on a plane, they're not flying home to their family in Philadelphia. And I think what's interesting in Miami in particular is that I have tried to, at our hospital, say, like, if it's hitting the West Coast slightly north, some people do evacuate south. It's sort of risky business, because if the forecast changes, then you're stuck. And then if you have to go north with everybody else, you're in hard times. But trying to sell that, like, let's hang out here for a minute, because if we have to offset relatively local, but where we're not impacted, in terms of our hospital system, that is a very hard message to sell, both to the hospital system, to people that want you, funders that want you out there and in the field and all that kind of stuff. And trying to say, like, let's hang back and hang out here and see how it goes and not get in the way and staff up our hospital to offset some of that. Because I think, from a hospital perspective, really thinking about those vulnerable patients, evacuating very locally, I think is a place to start looking.
Yeah, people become used to it.
Right, exactly.
Overall, for research purposes, the one who holds the information of where people go is the county. The county emergency management has its own plan, and that's how they know how many evacuation centers they need to open or not forth. So the county does know, especially on the flood levels and the storm surge. So they use those maps to know where people are going. In addition, at the university level, they, no matter what, any state institution, at least in Florida, they tell the students to go home. The only students that we at the university, and we have 50,000 students, is if they're international, they don't have anyone that they could go to. But even then, we tell them go to friend's house and so forth. But here, when it comes to Florida, each county has its own list, for example, of those, and usually elderly are the ones registered that they need assistance or they need some sort of mobility in order to get the evacuation centers. But the county is the one responsible to work with the Red Cross, which is the nonprofit sector, in getting those evacuation centers open and going. So they would have the most information on which ones have been open, how many people registered, so forth. So if you want that for research.
Okay, we have a couple of hands in the room, but before we go to the folks in the room, I wanted to, Mike, did you have a question as well? Mike Brennan, online?
No, I think I just was responding to Dave's point about how difficult it can be in real time. It's one of the things we struggle with, is just knowing where evacuations have even been called for, and what groups of people are moving and where, and what the compliance looks like. So it's definitely a challenge. it's nice to see some of this diagnosed and looked at after the fact, when we actually can start to piece together what's actually happened. Like you said, it can help inform how we may understand how people behave in future events. But it's a really difficult problem. So just leave it there.
No, and I'll reiterate what Mike said, like, because we have been trying for the last 2 years to find sort of national level data for evacuations, and it's tough. And as Dulce said, it's at the county level, and not all of them store the data in nice, neat ways that can be easily researched. So it's a struggle for us to even do studies like this at a national scale. And so I think it's something that we need to work on across federal partnerships as well, and to be able to develop some data sets where we have of this information at our disposal so we can actually start to study it. As you all do verification for all of the model data that you guys have, we unfortunately don't have a robust data set that we can kind of go back to study some of the work that's been going on. So with that, let's go to some of the folks in the room. Go ahead, Nick.
So I love hearing this, all these social science things, as Jisoo knows. I thought one thing was kind of interesting observing all the talks. This is all about, on the one side, having a forecast or a product. On the other side, the impact on an individual. A lot of the talks I hear about social science, and even in my own experience with being a minister during Isabel in 2003, going over my hometown, I hear a lot of talking about using communities and using community groups to do outreach and things like that. I kind of missed that in all the presentations here. So how does that kind of fit into what you are doing in terms of not necessarily talking to an individual, but talking to a church group or to a group of the DC Dutch people, for instance? So just name anything.
So I could say at FIU, and what we do is we try to have, for example, a simulation that I was talking about. We use that as that training where we could bring out all the community. Dr. Greg was, for example, one of the guests, but when I'm doing that planning, I'm bringing all that community membership because they need to know each other, but I'm kind of, because I'm FIU and I'm like a neutral, I'm not private or technically in public, but I'm neutral. So they feel that they could come and they could have that engagement, not just with the students, but with each other, and having that networking is very important. We also do it during hurricane season. So what happens is if a lot of these individuals do simulations during February and January, when June comes, they already changed, turnover is very high, they already got another job. So we try to do that there. With the community, with faith-based groups, with NGOs, we bring them as well inside. So we try to bring as much diversity as we can within a simulation. So preparedness, mitigation, those type of efforts for us are main focus for us to have a community building conversation on what the main problems are. So, and also bringing actors like the Seminoles. I felt like no simulation in the community was bringing tribals. So I brought in the Seminoles. So try to find the gap and mix them in as much as we can.
I would say for risk reduction, social cohesion, if you have it, is one of the most important sort of variables. And working as an NGO, I think everybody has that experience where if you're not partnered with people, local community groups, you're going to be relatively ineffective in terms of response as well. So I think that is like absolutely quintessential. And if you have it beforehand, social cohesion in your neighborhood, in a community, that offsets some of the danger because people are checking on each other. People are sort of using that herd mentality paradox for good. And on top of that, people can rely on each other in a less threatening, more comfortable way, staying at your friend's house, that kind of, those kind of elements that it should not be overlooked at all. And I think we should take into account all of that kind of stuff. And messaging really has to be tailored to a whole bunch of different people and identities and groups. And that may be slightly different for a lot of different people, which is what makes, I think, a lot of this, like getting the word out and how it's presented in an effective way so difficult because there's so many types of people working together.
So any way that has been measured and quantified how big that impact is?
In resilience, the idea of social cohesion is like pretty heftily wanting to be studied, I think, but off the top of my head, I can't think of anything, but.
It's really hard because you can't define all of those populations, so you don't have a baseline for measurement. And the reason that they are effective is because they know their own community and they're uniquely powerful in that community. So from a big data perspective of how do you know who they are in advance, how do you reach out to them, how do you know when something is coming, it fails pretty miserably. The best I have seen as a way to measure it is the HHS Empower program, which uses Medicaid or Medicare claims data to identify people on Medicaid who are using durable medical equipment, so something that requires power. Usually means they're pretty vulnerable in disasters and they have a hard time evacuating. In a disaster situation, the local emergency managers can ask for that to be turned on, and it identifies addresses. And so they send community partners out to check on each of these individuals, make sure they have backup oxygen canisters, make sure that they can help them get down flights of stairs in their wheelchairs, get them to shelters, get them whatever they need, and know that they're there, that they don't need resources. And so in measurements of that field testing, they were able to find 92% of the individuals on the list. And I think 1 out of 1,000 said that they didn't want to participate or didn't want the help. So when you're looking at effectiveness of reaching individuals, helping them when they didn't know they wanted or needed help, and using community partners to know the streets and the buildings to go and provide them help, that's an incredibly impactful, measured approach to doing it, but that's the best I got for you. Oh, go for it, Jacob. Sorry, we've been ignoring you. We apologize.
Oh, that's okay. I dropped a comment in the thing, but yeah, I'll chime in if.
I wanted to add to add a little bit to what you said, Hendrik, about and this might be antithetical to a lot of you where you study big data all the time. That you can study it though from a qualitative framework, because when you go into communities and you ask them their stories, you can automatically know by the language that they use which communities have social cohesion and which ones do not. And so this is not a big data problem or solution. It is about identifying networks and people knowing who to go to and identifying the resources that they have in their community. And some of the work that we are trying to do with the social network analysis and developing maps of where folks are communicating and how they're connected socially does help to identify where communities have greater social cohesion, because you can literally see it on a map, a histogram of social network analysis of you either have lots of little pockets or you have a big, beautiful like map of people being connected all over a community. And so part of the work that we're trying to do goes directly to that, Hendrik. We can't do it with big data, that it's incredibly difficult, as Laramie said, and we don't have good data sets for that, but we do have other mechanisms that we're trying to measure social cohesion from. One of the things that Jacob mentioned, and this is what Dave online, and I swear we're going to get to you in the back, I promise. One of the questions about putting an RFID tag on people during evacuations. So in my previous life, I worked for the Department of Homeland Security. It's where I built the community resilience portfolio there, Science and Technology Director. And one of the areas that I studied was public opinion research. And there was a new technology where we wanted to actually put RFID chips on license plates on cars so that we could, and it was only going to be put on for when they crossed borders, right? Because, you know, we care about the borders at Homeland Security. When you crossed a border or when you wanted to evacuate to better understand where folks were moving. This was met with such vigorous and vehement hate. And we're talking about a car, not a person. We're talking about a car that could just sit in a driveway and nobody could get into. There were so many privacy, intrusion. Like, Americans are fiercely independent. And sticking a tag on them, like, they will chip a dog in a heartbeat, but you try to put one on them and they will just vehemently protest to it. However, what folks don't realize is that there is a tracker that they carry around with them every second of the day. Right? And that's what Jacob was talking about, is that it's your cell phone. We can actually do this. However, this data right now is extremely expensive. It's expensive to mine, it's expensive to get, because they know how valuable it is, and how intrusive it can be. But I think that in time, with public-private partnerships in particular, we're hoping to try to get access to some of that data during very specific events and times, so that we can sort of see how folks are evacuating and moving. So it's a new area for us. We're definitely exploring this possibility, because it is a wealth of information that we want to be able to utilize for good. So yes, gentleman in the back.
Okay. Yeah, Stan Golenberg, HRD, and just a couple comments first, and then my questions is during Hurricane Andrew, I was having a baby at Doctor's Hospital the night before, and talk about denial. Someone mentioned in the first, I was in total, I could not, I'm watching it on the TV. I'm a hurricane meteorologist. I could not wrap my head that this, well, at that time we thought Cat 4 storm was really going to hit us. And
Self-preservation.
yeah, it's just, I was short circuiting. I just couldn't believe that. But it was interesting. My wife told me afterwards, she said the hospital was clueless on what to do to be ready. One of the biggest things, move patients away from the windows. I told her, get in the bathroom, do not stay near the window. And they weren't in the devastation area. So hopefully they're better off now. But so my real question is, I see, this is fascinating to me. You've covered so many things that I'm interested in, but I see one of the biggest things as far as the planning, mitigation, et cetera, is convincing each individual person, organization, whatever, to have their own plan. You know, when do they evacuate? Under what circumstances? What will they do? Where will they go? I lived in a mobile home for a while, and I knew if I evacuated, I'd go to a friend's house 5 minutes away. I didn't have to do it early. But what will they do? Where will they go? People who run out to the stores, 12 hours before the storm hits and go crazy, that's not planning in any way. But the other side of that question is, I see people freak out when they just get a tropical storm warning. And I know the particular situation that it might get minimal tropical storm force winds, a few gusts or something, and they just freak out. So it's like not to overreact and know when they really need to react to stuff. So thank you.
I think, you're going to get that variability and uncertainty. And I think that's where the forecast is just so essential. I mean, when you look back at when people down here reminisce about Hurricane Andrew, and you look at those old timey, hurricane track thing, it's just like Florida, right? And now I remember moving down here for a second time for right before Dorian. That was probably the biggest hurricane. And I live on Miami Beach, which is the barrier island on the east coast of Miami. And I remember Dorian kind of getting stuck over the Bahamas, which is like an inch away, from Miami Beach. And then there not being an evacuation order for Miami Beach because it was going to make a right-hand turn 8 inches away from my doorstep. And I kept thinking is that right? But with more certainty about that, the spread of who is freaking out and who is buying a generator and some beer is way more narrow. But with other emergencies like COVID, for example, people just didn't know what to expect, and they were all over the map in terms of their personal risk assessment, and they just didn't know how to make heads or tails of it. So I think that's where really the forecast really comes into play, so that people are making a way less of a disparate spread in terms of their own risk assessment, that most people are kind of going right down the middle. And in Florida, we're used to that. I mean, the hurricane where I was in a hospital was Hurricane Sandy, where I was in New York. Even as a Floridian, I was standing over the Cornell, looks over the FDR highway. It's actually built over the highway. And I remember standing at the window and looking down, and it's just water underneath the hospital. And I was thinking, God, look at that. You know, I didn't know that was going to happen when I woke up and went to work this morning. But like in Florida, that's unthinkable, you know, like just out of context of being somewhere else in the same exact event where you're just not used to it. You're not thinking in that zone. I mean, that's where that kind of mental preparation and that really having those honed forecasts, I think that's where the money is in terms of making those decisions. Yeah, for sure. Yeah.
She said everything I could have said.
I would say that, you know, I deal with a lot of emergency management at the county, at the city level and so forth. The reality is that they don't have sources. You know, it's 1 or 2 people, 3 people. I mean, they're a very, very small team. And it's a sad reality. Even at the hospital level, you have a small team to respond to so much population. And all their efforts go on response and recovery, kind of like what I presented. And so when I tell them, hey, do you know how many individuals in your county have a disability? How many of your population is, you know, Spanish speaking only or English speaking or Creole? They don't have that information and tell me, how do I find out? And I'm like, the census. I mean, I'm a nerd for the census. I love the census. But when I give them an intern or a graduate student, I said they can get that information very easily for you. They're like, oh my gosh, that would be amazing. So the resources that they have at the county level, at the city level are very, very minimal. And so most of their efforts go on the response and recovery. If they do preparedness, is usually like on non-hurricane season months. After that, they're just on one over the other. You can't even reach them. So I tell them, go to the community, is really understanding who's in front of you, who is your population. For example, FIU, we're right next to Sweetwater. Sweetwater is a rental community, 100%. What does that mean? That they're living paycheck to paycheck. If they need water, they're going to come to FIU. If they need shelter, they're going to come to FIU. If we're not prepared for them, then that's on us.
My favorite disappointment, you asked if this got any better, if things had changed since your experience. In 2016, the Centers for Medicaid and Medicare Services passed something called the Emergency Preparedness Rule that required every one of 17 different types of medical facilities. So hospitals, nursing homes, rehab centers, all sorts of different things, to have 2 emergency preparedness exercises every year, one a tabletop and one a full-scale exercise. This is absolutely amazing because it means not only does everybody need to have a plan developed, but these exercises are so hard to do and so expensive that they said, if you want to do them as a community, that will count. And so it's getting all of these different groups to have a whole of community approach and bringing in their individual unique community groups to help have this collective whole of community preparation. Now that's only for the healthcare communities, healthcare facilities, but it means that we're moving in the right direction, that we are starting to invest more in preparedness, even if it's not large financial amounts, in the amount of effort that we're putting into it. People are starting to learn finally that there are better ways to prepare, better ways to get our communities together, better ways to take advantage of our unique resources and capabilities and save lives in disasters when something happens. But it's not working very well, so that's why it's my favorite disappointment. We'll get there.
All righty, everyone. Thank you so very much. I want to just thank you all for letting a couple of social scientists crash your little modeling party and for this wonderful invite. It's been great learning from you all. Hopefully we can continue to do it in the next couple of days. Please come up and speak to us. We'd love to have conversations to better bridge this. It's not a gap. It's just trying to figure out the space where we two coexist together so that we can fulfill the mission. So thank you all very much.
All right, before we go to our break, I want to ask everyone that's in the room if you appear so we can do a group photo. And those of you online, if you